So I'm going to present to you some of the research work that we're doing here at NYU and some of the changes that we've seen in the development of how we treat melanoma and how we've really taken it from a disease that really had no right answers and no real treatments that were very helpful in prolonging people's lives to really changing that. All of these changes came about in the year 2011, so very recently. So like Dr. Shapiro had pretty much summed up this slide, melanoma is clearly the most deadly of all skin cancers. It's number 6 for men and number 7 for women, and common in young women. And as you can see, this is just showing how the trend for melanoma is continuing to rise. This is an older slide. This is in 2000. It was 1 in 74. And now in 2013, it's probably 1 in 50. So that trend continues to increase. And that's a very dangerous number because it just says that what's going on and why are more people getting melanoma? And so we think that people are getting more melanoma, number one, because they've been exposed to excessive amounts of radiation. Because let's face it, growing up, we didn't realize how bad radiation was for us. I think most of us have gone tanning or gone to the beach and not had sunscreen on when we were children. I remember when I was young, my parents used to get all 12 cousins together and we used to go down to the Jersey Shore. And one of the things we used to do was, who had fun putting eczema on who, because you all got sunburned that first day because you didn't wear sunscreen and your parents had you out on the beach. So more people are getting melanoma. More people are developing invasive melanomas, and we really need to raise awareness to make sure that patients don't get melanoma, because most people truly believe that melanoma is a disease that is a skin cancer that you just cut off and you don't have to worry about. Well, it's not. Melanoma is something that can spread to other parts of the body and really can be life-threatening. So let's talk about some of the therapies that have evolved over the last few years that have really changed what happens to patients when they get melanoma that goes to other parts of their body. And all of what I present to you here is research that we've done here and have been elemental in really getting to the FDA to get these drugs out there to patients, not only at big academic centers, but also in the community. So we're going to talk about 2 different types of therapies tonight. One is immunotherapy, and one is pathway blockers. So you'll notice as a medical oncologist, I haven't said anything about chemotherapy because the way we treat melanomas in 2013 is not with chemotherapy, it's with immunotherapy and these pathway inhibitors. So what is immunotherapy? Well, immunotherapy is where we try to get the body's innate immune system to recognize the cancer cells as being things that really don't belong. So if we could educate and stimulate your body's immune system, namely the T cells, to recognize your cancer as something that really doesn't belong, we can get those T cells to attack the tumors and ultimately help control, if not cure, the melanoma. What's good about this is that immunotherapy doesn't affect normal body cells. When you think about chemotherapy, chemotherapy affects cells that are rapidly dividing. And so you can have mouth sores, you can have blood counts that fall. Immunotherapy does not do this. However, immunotherapy does have its share of side effects, and we'll talk a little bit about what they are. So one of the things that we've developed is what we call a monoclonal antibody. A monoclonal antibody is a drug that targets a specific receptor on a T cell. And I'll show you a cartoon next about exactly how this drug works to help you understand why it can be so effective. But by using these immunotherapies, we try to take the brakes off the immune system. Again, allowing the immune system to go out, find what doesn't belong, attack it, and get rid of it. However, like I said, there are side effects, and those side effects are immune side effects. So what exactly are immune side effects? Well, I tell patients immune side effects are the itises. Dermatitis, meaning itching. Itching is pruritus. Dermatitis, meaning rash. Hepatitis, we can inflame the liver. Colitis, diarrhea. So anything that we can cause inflammation to is what an immune drug can do. So these are the cartoons that describe exactly how immunotherapy works. This red cell up here is a T cell. T cells are constantly in your body surveilling, looking for things that don't belong. Well, they behave very benignly until they come into contact with what's called an antigen-presenting cell. And these antigen-presenting cells are the cells that say, hey, listen, there's something going on here and you need to go get it. So they hook up here, and when there's a hookup, a linkage between the T cell and the antigen-presenting cell, all of a sudden the T cell becomes very activated, and it starts putting out all of these, what we call cytokines or chemicals, that stimulate other immune cells to come into the area to attack. However, T cells are very smart. So this T cell has an extra receptor here called the CTLA4 receptor. That receptor is the brake to stop T cells from behaving uncontrollably. So when this T cell starts being activated as a protective mechanism, this receptor comes out onto the surface and says, look, here's another receptor. The CTLA4 receptor likes the B7 receptor a whole lot better than it likes the CD20 receptor. And when the CTLA4 and the B7 interact, the T cell shuts down. And so all T cell stimulation is stopped. So how does a monoclonal antibody work? Well, when we get the CTLA4, when we get the T cells active and the CTLA4 receptor comes out onto the surface, if we have patients who are receiving this antibody, we have this protein that's floating along looking to hook up with this receptor. So you have the CTLA4 monoclonal antibody and you have the receptor, and when they join together, it blocks the CTLA4 from hooking up with B7, and the T cells keep doing what the T cells are doing. They keep making cytokines, they keep sending signals and say attack, 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 attack. And that's the mechanism behind how immunotherapy works. What are some of the side effects? Well, I said dermatitis. These are some of the rashes that you can incur when you get this medicine. What's important to know is only about 20 to 25% of patients who get immunotherapy have any side effects at all. Some patients who get this therapy have no side effects. Some of them have rash, some of them have itching, some of them have rash and itching together, some of them have diarrhea. But we know how to manage them. We've been critical in getting this drug developed because we've worked with this drug here at NYU for over 10 years. We were part of the first group of physicians who ever got to work with this drug. And trust me, it was a very steep learning curve for us because we saw all these things happening to patients, and we as oncologists think of things like chemotherapy, so we use the methods that we used to treat patients with side effects of chemotherapy, but they really didn't work for immunotherapy. So we had to learn how to control the side effects. Well, here it is now, 13 years later. We're very good at controlling the side effects, and that's why patients can go through these therapies pretty much still working with minimal toxicity. They do not lose their hair. They do not get nausea or vomiting. In fact, most people wouldn't even know that you're getting any therapy at all. I have full permission from this patient to show his profile. Why is this important? Because we were also one of the first institutions to document that when patients have good responses to this medicine, their bodies, their T cells, are out there looking for melanoma tumors. What are melanoma tumors? Melanoma tumors are tumors that are made up of cells called melanocytes. Melanocytes cause pigment. So this gentleman comes into my office, and he had gotten immunotherapy. And he also would like to tease me all the time. And I said, what in heaven's name did you do to your eyebrows? And he said, what do you mean? I said, you have skunk tails. You have skunk tails over your eyebrows. That's not normal. What did you do? And he says, Doc, I swear I woke up with them. So I thought he was teasing me. But as he continued to have a response, and as his melanoma continued to shrink, and as his immune system continued to attack not only his melanoma, but also other cells that caused pigment in his body, he started to turn white. And so this gentleman has now had a complete resolution of all his melanoma. He had a big melanoma tumor in his heart. If we go back, we can see he had in his nose, in his sinuses, and in his heart. And he's now completely white. His eyebrows are white, his hair is white, but he also has no melanoma. And so we've also seen that in other patients who go on to have complete resolution of their melanoma, their eyebrows and their hair start to turn white as well. So one of the other things that we looked at was, can we combine immune therapy with other things to try and stimulate the body's immune system? Well, we know, we heard from Dr. Sanfilippo, that radiation can in fact be very helpful in controlling melanoma. Well, when we radiate a tumor, when those tumors get broken down, they release proteins into the circulation. And we think that those proteins may be able to act like homing pigeons and direct these T cells to where those proteins are. Well, where are those proteins? Those proteins are in the melanoma tumors somewhere throughout the body. So we're now doing some research saying if we give patients this immunotherapy, the CTLA4 monoclonal antibody called ipilimumab, and we give them a little bit of radiation to break down that tumor so we can release proteins into the circulation, can we get more people to have the same good response that we saw in that other gentleman? And so this is a study that's currently going on right now. I bring up another drug called anti-PD-1 because if you read any of the papers, everybody asks about anti-PD-1. Well, anti-PD-1 is another immunotherapy. It is what we call the next generation of immunotherapy because we think that we may have been able to make this drug better than the ipilimumab that we were using with less side effects and actually have more people have their immune systems turned on and be successful in controlling their melanoma, probably to the tune of almost 50%, which is pretty amazing when you think back to before 2011. The ability to control patients with melanoma to other parts of the body was less than 5%. And now we're talking 50%. So this is really exciting for us. And we're also doing those trials here, and we have patients with metastatic disease who come in and say, hey, listen, I want to participate in this research study. And we strongly advocate that because these are the stepping stones to our future. You can get standard therapy anywhere. You can't always get the cutting edge things that you can get when you participate in research. And that's why research is so important to us here. So my talk wouldn't be complete unless we talked about pathway inhibitors. And there are two pathway inhibitors that we're going to talk about tonight. The first one is BRAF. And this is a crazy busy slide that just goes to show how crazy and busy melanoma is. And melanoma likes to divide and go down all kinds of different pathways to spread to other parts of the body. Well, we found out that the one pathway on this big crazy slide that it likes the most is this pathway, the RAF pathway. And we found out that 50% of patients who have melanoma that go to other parts of their body, their tumors will develop an alteration within that tumor called a mutation. That mutation is called a BRAF mutation. If patients have a BRAF mutation, we have been able to create drugs that block BRAF. If you block BRAF, guess what happens? You don't have that stimulus. You don't have the driver that says keep dividing, keep going, and you give patients a BRAF inhibitor medicine, guess what? Their melanoma tumors start to shrink up within 2 weeks. It's dramatic. but you have to have that mutation for this medicine to work. If you don't have this mutation and somebody wants to try that medicine, it does just the opposite. It actually speeds up the disease. So it's very, very important that us as researchers and us as medical oncologists make sure that patients have their tumors checked for this BRAF mutation, because this may provide them with a treatment option. What's really important, and what patients always ask me, is that if I have a mutation within my tumor, is this a mutation, a genetic mutation I can give my children or I can give my family members? And the answer is no. This mutation only occurs within the tumor. And so it's unique to your tumor. It's not transmittable. It's not a genetic thing you're going to give to your kids. It is just a way for us to maybe use a medicine to better control your tumor. So, like I said, 90% of BRAF mutations are found, and 50% of patients who have metastatic melanoma will have this BRAF mutation. So the thought is, if we inhibit the signal that says keep growing, keep growing, keep growing, we should easily be able to control your disease. And this is actually the genetic code. We take DNA right from the tumor and we do these tests. This is a person who has a wild type melanoma, which means they don't have a mutation. And these are patients who do have the mutation. So again, this is the pathway. We know that 50% of patients have an alteration right here. When we block this pathway, the cells stop dividing. So we have two medicines. Well, we have one medicine right now, and we have one medicine that's going to be FDA approved probably in June that block BRAF. Why is it easy? It's easy because it's pills. We hand patients some pills, they take their pills, they go home. Again, not chemotherapy, not going to lose your hair, not going to get nauseous. However, will you get side effects? Maybe. You might get a rash, you might get some joint pain, you might get some muscle pain, but you're probably going to watch your melanoma tumors shrink up right in front of your eyes in a very short period of time. And so we really thought, oh my God, we hit the home run. We've been able to shrink tumors up really quickly. We got this under control. We're good. We're sitting there thinking, we fixed this. However, we were wrong, because we can fix the problem, but we can only fix the problem for a defined period of time. Most people who get one of these medicines, one of these targeted therapies, will have their disease controlled somewhere between 9 months and roughly a year and a half. After that, the melanoma gets smart, and it figures out how to grow around that blockade. And so now it's up to us to outfox that fox. And so we're looking at other parts of that crazy pathway to find medicines where we can put up more than one blockade, but we could put up 2 roadblocks. And we found the other common pathway that melanomas like to grow around. So if we block BRAF and we block this pathway called MEK, guess what? We can double the amount of time that patients stay in remission. Not what we want. We want to fix this completely, but clearly we're on the right path, because we've taken patients who now have disease being controlled for 9 months to a year and a half to now a year and a half to 3 years. Again, we're talking about people with disease that goes to other parts of their body, where 5 years ago, the chance of us doing that was only 5%. So we've come a heck of a long way in a very short period of time, because we've been able to learn more about the genetics of people's tumors. And this was actually one of the research studies that we participated in. And this is what we call a waterfall plot. The top of the curve shows patients who had no response to the drug, and these are all the patients who got benefit. So pretty much, it's not 100% of patients who benefit, but it's almost 75% of people who get a BRAF drug, if you have a BRAF mutation in your tumor, get a response from this medicine. And again, ugly picture, and I'm sorry, but this is to show melanoma nodules on somebody's chest wall. This patient had a BRAF mutation and participated in one of our research studies. And you can see nice, clean, smooth skin. You can still see the scars where the nodules used to be, but those nodules are gone, and this is 14 days later. This is how quickly these medicines work. And patients will say, well, that's nice, but does it work on the inside? And the answer is yes. This is a CAT scan of a patient. This is their liver. This is 2 big tumors within their livers. Look at what happens. Over time, the longer you take the medicine, the more the tumors continue to shrink. And as Dr. Shapiro showed you, this is a PET scan. So you can see all the hot spots. This is a hot lymph node, and this is a patient with a leg full of melanoma tumors. And here you have the same leg, not all gone, but clearly within 2 weeks, drastically better. And so now we have this category of drugs called MEK inhibitors. They are not yet FDA approved. We anticipate that this drug will be approved also in June with the other BRAF inhibitor. And we would expect that the new standard, the way that we're going to treat patients who have BRAF mutated melanomas, is to give them a BRAF drug and a MEK drug, because again, when you give both, you double the time for patients before their tumors start to get smart. They're both pills. And interestingly, we were really worried about giving these 2 medicines together because we were afraid of the side effects. But when you give a BRAF drug and a MEK drug, they almost balance themselves out, and patients actually have less side effects when you give both than if you gave one or the other. So it really turned out, it was a very good study for us to do, and like I said, those drugs should be available within the next 2 months to our patients. And this is what we talked about, was combining them. We're also looking at other drugs or other pathway targets in that crazy melanoma pathway that we combine with the BRAF inhibitors. We're also looking at taking these BRAF drugs and combining them with drugs called anti-angiogenesis drugs. These, again, not chemotherapy, but medicines that can try to cut off blood flow to the melanoma tumors, because we know that melanoma tumors have lots of blood vessels and they're very vascular. So if we can cut down the blood flow where they can't spread to other parts of the body and they can't get the nutrients that they need with all those blood vessels, maybe we can even do better. So in conclusion, I hope you're as excited as I am about some of the advances that we've been making in a very short period of time, and how excited I am about actually being a big part of being able to change what happens to patients with melanoma. We're not there yet. However, we have taken a huge step forward, and with the knowledge that we have about the genetics of tumors and the importance of data banking and looking at what happens within the tumor, we're able to better find targets and ways to combine beefing up somebody's immune system and maybe hitting a target together, or finding ways to better enhance somebody's immune system where we can control their melanoma for the rest of their life. So I think we're making good strides, and again, I thank you for your attention.